Good morning, my name is Erica Dry, and this is my presentation for the Collaboration and Leadership Reflection video for Nursing 4010. This presentation will reflect on an interdisciplinary collaboration experience that I was part of within the past year. I will discuss the aspects of the situation that promoted effective collaboration, what hindered it, and how to improve for future circumstances. In this video, we will look at how subpar collaboration in the healthcare setting can negatively affect patients and the hospital's financial resources. We will explore leadership practices and how they can positively influence collaboration among the healthcare teams. We will also investigate strategies to promote optimal interdepartmental collaboration. Lastly, I will reference peer-reviewed articles throughout this presentation and will include these references in an attached document. To start off, as a critical care nurse, our unit tends to see patients at their worst. Overall, our department is well accustomed to collaborating with the healthcare team, as it's essential in order to promote positive patient outcomes. For us, it is a daily occurrence to be working alongside our intensivists, cardiologists, general surgeons, members of the anesthesia team, and other ancillary staff, such as patient care aides, respiratory therapists, and social workers, to name a few. In this situation I will be reflecting on today, we will be focusing on a medication error, which also brought pharmacy team members and patient safety advocates into the mix. I personally had just received a new admitted patient from the emergency department. The patient was intubated for respiratory distress. However, after intubation, concerns were raised regarding the patient's neurological function, which was intact prior to the procedure. However, by the time the patient arrived to me, she was unresponsive and had a Glasgow Coma scale of 4, significantly lower than what we typically would expect at this point. As soon as the patient arrived to our unit, it was clear to me that the titratable fentanyl drip was infusing far too rapidly. Upon inspection, it was noted that the medication was entered into the IV pump as a weight-based calculation, something I had never seen in my career, and such it was currently infusing at a rate 6 times the normal dose. Due to this mishap, the patient ended up having a head CAT scan done, and when that was unremarkable, she also had a lumbar puncture performed as well to rule out any infection. I was able to communicate quickly with my critical care provider about what I had found, and despite the mistake being noticed, we still had to continue with the interventions listed above to rule out any other complications. The night shift pharmacist had called me to verify what the drip was infusing at, as he had just started his shift and noticed the error. Unfortunately, I was not able to review the medications with the ED nurse who had delivered the patient to the ICU. Otherwise, it would have been a wonderful opportunity to collaborate with the nurse in another department to prevent this incident from happening again. Another problem that led to this circumstance was how the IV pumps were programmed from an IT perspective. Weight-based formulas were the only available option when selecting fentanyl from the pre-programmed drug list. Unfortunately, in order to get around this programmed formula, you would need to reprogram the pump to infuse as a basic set, which bypasses any safety parameters and lockout functions to protect the patients in this case. The poor collaboration started in the emergency department. It should be noticed at this point that the emergency department has a separate pharmacist who works solely in that area and remains bedside during emergent times, including intubation. Perhaps poor communication preceded this incident, but had the ED pharmacist been involved in the medication administration, this situation could have been avoided. It's also uncommon from my experience that emergency medicine providers are ordering narcotic drips. Usually these types of infusions are managed by the critical care team. In this case, the hospital cost the family a significant amount in unnecessary tests and procedures, some of which were highly invasive and put the patient at an increased risk of infection. Had the patient developed an infection while hospitalized, more than likely the hospital would have had to pay for the interventions needed to treat said infection. In Scott's 2020 article, Working Together, the authors discuss how disciplines are accustomed to take over other tasks during emergent situations. The article also goes on to discuss how collaboration in acute care settings involve ongoing negotiations between several professions. Negative effects on patient care were also examined as staff performed informal workarounds. How I had mentioned previously about programming the pump as a basic set could be one of these workarounds. While this incident occurred during the off hours, many times leadership and management are not present during such times. This event was quickly escalated to the appropriate channels the following day. According to Bergstedt and Wise' 2020 article, Leadership Strategies, the management team of the ICU displayed authentic leadership and transformational leadership strategies following this situation. Both the unit managers and the department director arrived early the following morning to discuss the event and went as far as escalating this to the chief nursing officer, chief medical officer, and also involved the director of pharmacy and the patient safety team. I personally had several meetings with a number of individuals previously listed, and ultimately my management team kept me engaged and empowered to voice any concerns and recommendations to prevent this from happening again. Regarding collaboration strategies, interdisciplinary bedside rounding has become common practice in many nationwide hospitals, according to SHOT's 2020 article. In this specific case, had time allowed, it would have been helpful to include the emergency department nurse to review the medication infusions with me. Both the ICU and the ED have examined their education curriculum involving medications and IV pump infusions. Another helpful strategy is having standard protocols in place, as well as standardized order sets pre-programmed into the electric charting system. In Saeed et al.'s 2016 article, stakeholders are able to support and facilitate staff acceptance to change within the system. Currently, network-wide, stakeholders are overhauling the entire fentanyl order set in the electronic medical record to standardize the administration and are working on upgrading the IV pumps to prevent this from happening again. With these changes taking place, overall, this collaboration should be proven successful and prevent further negative outcomes for our patients. Thank you for joining me and reflecting on this collaboration and leadership video.